Together, here we go. All right, so we're going to talk about personality disorders, type symptoms, and treatments. Now, I will preface this by saying all of the medications on the market, none of them are approved for a specific personality disorder. But you've been in this class long enough to know that it really doesn't matter what disorder I label you with. It's all about what symptoms are you having or what is the circuitry at play. So what I'm going to do now is present to you the personality disorders, but I've mapped them to, and I just posted them this morning because I had a new thought about this presentation. So while I was in the shower, I was like, I have to redo this. So I redid the slides this morning and reposted them. So now you have new personality slides there. But suffice it to say, I've mapped them to the research domains criteria because it's those symptoms that people are coming to you with, essentially saying, I have this. Nobody walks in saying, I have this personality disorder. If they do, that in and of itself makes me think they're right. And so what I have to figure out is, well, what am I going to do? How is this affecting you? So what we're talking about are behavioral manifestations that people have, that if they have enough of one kind in a specific area, they're going to qualify for a personality disorder. We think that personality disorders affect anywhere from 9 to 15% of the population, which means it's pretty high. Now, you may have personality disorder traits, but for the purpose of the DSM, we don't call it a disorder until you have enough traits in one domain. Also, you don't want to get to the point, even though you get good at this, where you label a personality disorder from the door. You're also not supposed to label a personality disorder in someone that's not yet done developing, specifically teenagers. But I've talked to enough mental health professionals and they'll walk and say, that's a borderline, that's a narcissist, a borderline, a narcissist, a borderline, right? They do it from the door, essentially. You'll hear the phrase, oh, look at that budding borderline, right? And so you've heard these phrases before. Officially, though, this takes a getting to know you, and you have to make sure that you are not just seeing them in a particular context, because context matters. What you don't want to do is diagnose people on television. Now, there's a lot of money in diagnosing people on television because they want you to be the guest speaker on whatever show. Don't do that. It undermines your credibility. That psychiatrist from Yale that decided to label the president with narcissistic personality disorder in his last term, she's no longer to be seen. Because while it looked good and she got a lot of airtime for doing it, and you may really be convinced he has this, you don't know if that person is playing for the camera or playing to a context or doing something, and that's not how they act in multiple domains of their life. Now, obviously, you need to meet the person one-on-one, but you also need to get corroborating information. You can't just go on the corroborating information. That being said, people with narcissistic personality disorder typically do not come to treatment because they don't believe they have a problem, unless it's compelled. Most of the other disorders will come so long if it spills over and affects other people. The one you're most likely to see in treatment is the borderline personality because they tend to hit the radar of a lot of people, and then you will get to see what all the behaviors are. Personality disorders are broken into three clusters, cluster A, B, and C. Cluster A is the odd, eccentric disorder profile. These are the paranoid personality, schizoid personality, and schizotypal. I will show you the distinction between this, but I'm not going to spend a lot of time getting you to diagnose the difference. That's Nursing 777. They get it in that class, so you can get it from them. But suffice it to say, here they all are side by side. But I also put schizophrenia up here. Schizophrenia, we told you, was a thought disorder. There's pills for that, but there's no pills for schizoid, schizotypal, and paranoid. The problem is people are less than careful when they diagnose. And so if they have any one of these things, people are very quick with the atypical antipsychotics. You have to ask yourself, what functional problem is this causing? You can be oddly related and wrap your head in tinfoil, but if it's not bothering anybody and you're fulfilling your ADLs, why are we treating this situation? Because that host of complications that come from the meds are going to be worth dealing with. Cluster B, this is the dramatic, emotional, erratic personality. These are the ones on television. These are the exciting ones. These are the ones that you might see on the housewives of whatever county you happen to be watching, right? This is the where you screaming and flip the table people. This is where you watch, I don't know, my wife watches Bravo and there's a guy who interviews all the housewives and you can see his disorder and their disorder all coming together on the screen. It's very entertaining until they're in your life. And then it's less than entertaining. The antisocial personality disorder, there's an ethical conundrum here. There is a genetic variant that is known to lead to this specific disorder developing. The problem is, what do you do about it? Because there's no treatment for this. There's no cure for this. So the question is, should we diagnose people for something for which there is no cure? Might they be harmed in the process? What harm are we causing them? Are we casting the die to say they're going to act this way? The borderline personality, this is the one that talks about the unstable emotions, impulsive actions, intense fear of relationships, often leading to emotional turmoil. This is the help me, leave me alone. I love you, you're perfect, now change. This is the one that's afraid that someone's going to leave them all the time. This is the one that the meltdown always happens around the issue of an anticipated abandonment. So that's a good way to figure out why the symptoms you're seeing are being manifested. The histrionic personality disorder, this is the attention seeking. This is the one that might walk in here with a feather boa. This is the person that comes in here with the extreme makeup, the big hair, the loud shoes, the whole I'm constantly drawing attention to me. But they're not malicious. They're not hurting anybody. This person will laugh out loud and cry emotionally in the same breath. But they're not harming anybody. They're really just motivated by drawing attention to themselves. That's different than the narcissist who not only wants the attention to himself, but wants to be thought of in very glowing, aggrandized terms. The histrionic just wants to be thought of. Good, bad, indifferent, crying, happy, they don't care. Just think about me. The narcissist says, tell me how wonderful I am. Tell me more. It's never enough, right? So that's kind of what they're about. Also, the narcissist is the one that's using you as a means to their end. So that's the problem there. They're very charming. They know how to draw an audience. They're only going to keep you in their orbit so long as you're providing supply. So one of the issues we have here is borderline personality disorder will often get mislabeled as bipolar disorder, and this is how they wind up on this whole cocktail of medications. Take a look at this middle column here as to the overlapping symptoms. This is why it's really important that you're very careful in how you diagnose anybody with anything. We don't have a cure for either of these. There is medication approved for bipolar. There is not for borderline. So, and the medicines are not benign. But take a look at these overlapping symptoms of impulsivity, aggression, emotional lability, mood reactivity, suicidal ideation, dysphoria, and paranoid thinking. Now, keep in mind, in order to be a disorder, it has to be an enduring trait. It has to be enduring, meaning over time. It just can't be situationally induced and then it goes away when things back to normal. So that is the distinction in your notes when I talk about the difference between a state and a trait. The state, this is your method of being. A trait, it's flared up for some reason. The other final cluster is this cluster C, anxious and fearful disorders, avoidant, dependent, obsessive compulsive personality disorder. Let me just show you this next slide here so we can know how to distinguish them. But OCD, obsessive compulsive disorder, there's a pill for that. OCPD, there's no pill for that. The main difference is the ego dystonia. The OCD people are bothered by their obsessions and compulsions. The obsessive compulsive personality people think everybody should be doing it their way and they're proud of it, right? So that's the big distinction here. That's why it's really hard to treat personality disorders, because personality disorders are often egosyntonic. They're good with it. They like it. They think they're doing the right thing. This is the way everybody should be. I'm very careful. I don't do that. Neither should you is the implication, right? So you can see these people. In the post-COVID era, you can definitely tell the personality disorders leaking out all over the place, right? This is the same person today who will come in and start handling everything with gloves and mask up and condescend to everybody else because they don't do the same. Right? This is the same person that will insist not only do they wash their chicken, but everybody else should wash their chicken, and anyone that doesn't wash their chicken is going to hell. right? That's that kind of OCPD where they're trying to proselytize and convert everybody. So let's talk about symptoms and diagnosis. So these are the common symptoms across the different disorders. This is what makes it a disorder. This is what brings it to your attention. If they're having difficulties in relationship, a distorted self-image, impulsivity, and emotional instability, this is the stuff that says you need to see somebody, right? It's like from the first lecture I told you, the thing that brings any of this to your attention is the outward factors. The external features is what rises to the level of needing to make those things internal, right? You need to contain yourself, pull your stuff together. You can't act like this. If you do, hospital. That's basically the world we live in. So the diagnostic criteria requires this comprehensive evaluation to make an effective diagnosis. You can pull up the DSM-5 criteria. Suffice it to say, it's not going to change what you're actually going to do. It's academic. It's for billing purposes. Remember, we told you there is no thing called mental illness, right? There is no thing, discrete thing called mental illness. We have a constellation of symptoms and signs that in the absence of another explanation, we're going to call a disorder. But the minute we find another reason, it goes outside that domain. If it's an underlying medical condition, if it's substance-induced, if it's malingering factitious, if it's adjustment, meaning a normal reaction to stressful life events, we're no longer calling that a disorder per se. So that's why it's important to be clear so we don't go around mislabeling people. So what causes this stuff to happen? Well, there are some genetic influences and family history. And family history does not just mean genetic. The family history can just mean learned behavior. How did you learn to act this way? Right? That's the question that you're asking about every patient that walks into your office or that you're seeing. Why are you acting this way? How did it come to be this way that you think this is an acceptable way to act? Where did you learn this? Or is there something acting on you that is making you do this? Like, are you doing this because you're under threat that if you don't come here and act belligerent, are you standing to win a bet? Are you being held at gunpoint? Did your whole family act this way and you think this is normal? Why do you act this way? That's part of the family history. So this is why I recommend you look at all of your patients, be they adults or children, as identified patients. The identified patient, remember, that just means this is the person that their system has agreed upon to be the sick one. The reason we like that term is because it allows you to consider the fact that maybe your patient is normal given the context from which they come. What if they are just doing the best they can given where they come from? We don't know where they come from. That's the getting to know you process. We don't know about their childhood trauma, their neglect and adverse experiences, we don't know any of this. All of these things, by the way, are the moderating factors as to why your drugs may not work as well as you think they ought to work in that individual. Now, there is an interaction between the genetics and the environment. We call that epigenetics. We're talking about genetic predispositions, but also the exposures you've had over your life, the social context, the upbringing, what you're exposed to now, what your frame of reference is. All of that is the interaction between your genetics and your environment. Just because you have a gene, it does not mean it's going to express. And you may express without having a gene just as a product of your environment. And some things you need both product, you need genetics and environment. For example, if you're genetically predisposed to alcoholism, but there's no alcohol in your environment, you can't become an alcoholic, right? You need to have access. If there's no access, and sometimes the treatment is just simply aimed at modifying the environment. When you see the patient who's the identified patient, you say, oh my God, you are acting normal given your chaotic environment. I could A, medicate you so you don't care about your chaotic environment, or B, maybe we need to change your environment. And that's the question you're asking. So what does treatment and management look like? So you've heard of the ACE scale. This is the Adverse Childhood Events Scale. This is a 10-item question scale looking at things that you would ask your patients in a history. Emotional abuse. Did a parent or adult in the household often or very often swear at you, insult you, put you down, or humiliate you? And you score these on a scale. And did a parent or physical abuse, did a parent or adult in the household often or very often push, grab, slap, throw something at you, or ever hit you so hard that you had marks and were injured? Sexual abuse. Did an adult or someone at least 5 years older than you ever touch, fondle you in a sexual way? Have you touched their body or attempt to actually have oral, anal, or vaginal sex with you? Did you often feel that no one in your family loved you or thought you were important or special? Did you often feel that you didn't have enough to eat, had wear dirty clothes, or no one to protect you? This is the Adverse Childhood Events Scale. So the question is, you would actually ask your patients this. They're telling primary care to do this as well. Mother treated violently. Was your mother or stepmother often pushed, grabbed, slapped, or had something thrown at her, repeatedly hit, or threatened with a weapon? Did you live with anyone who has a problem with alcohol or drugs? Was there a household member who was depressed or mentally ill, or did a household member attempt suicide? Were your parents ever separated or divorced? Did anyone in the household ever go to jail? And then what happens is you pick one for each of those and you rank them. If they have more than 4 of these risk factors, they're said to be at very high risk for mental health disorders, addiction, early mortality, less resilience, from that previous lecture of PTSD, etc. So if you look at that, and then you consider, well, what symptoms might they have that you are now calling a personality disorder? The upshot is here, maybe they needed to have those symptoms in order to survive those events. So if they had emotional neglect, this downregulation of oxytocin receptors, they may have had to act detached just as a way of being, as a way of coping. They had to care less. You do this over years and you habituate the behavior, maybe now you will manifest symptoms of schizoid personality. What about physical abuse? This upregulates the amygdala and reactivity. So maybe you live in a hypervigilant state leading to paranoid personality. Not psychosis, paranoid personality, just kind of like I'm cautious about everybody. If you were sexually abused, this cortical receptor methylation process was affected, and maybe you have this sensuality disassociation. This histrionic person could be hypersexual, or they could be completely shut off and avoidant. Maternal abuse, limbic system sensitization. Maybe you're empathic or to the point where you're raging or enmeshed. You are basically looking for what behavior did you learn at the time of the childhood events that you have habituated over time that has now formed your personality. Another word for personality is character. They used to call them characterological disorders or characterological problems. The way the character forms is through habituation. So what that means is we want to teach the child to habituate adaptive coping mechanisms and good behaviors so that forms their character as an adult. But if you force the character to form in a maladaptive way, that too will form the maladaptive adult character / personality. So how does this translate? Well, you know about the negative valence, positive valence, cognitive, arousal, and social systems of the RDoC domain. So if you were having negative valence symptoms, this ACE-linked dysregulation is you are fearful of a chronic threat exposure. You may manifest with hyperarousal and re-experiencing, right? Those are those PTSD and personality disorder symptoms. That's who we're giving SSRIs and prazosin to those negative valence symptoms. The positive valence symptoms may manifest, this is your impaired reward processing. Positive meaning you're showing symptoms. So you may have impulsivity, addiction, or even anhedonia on the other side. And so this is the person you're doing bupropion or naltrexone with. Cognitive symptoms could be impaired with attentionality and memory. So if you may have rumination and suspiciousness, so this is the person that you're using the atypical antipsychotics with. Arousal regulatory disorders. This is the HPA axis overactivation. Maybe you're manifesting this by poor sleep or being dissociated from your symptoms. This is the alpha blocker and trazodone person that you are trying to contend with here. Okay, let's see. So RDoC based on pharmacological reasoning. So this RDoC framework is, like I told you, transdiagnostic and neurobiological. The whole idea here is we're working with the circuits. We're not saying one chemical, one process. We're saying this causes downstream effects. These are secreted by this part of the brain. This is why we're matching this drug to that symptom. The idea is to clarify the target symptom and so that you can be a little more precise rather than depression, SSRI. Right? We don't want to do disorder drug. We want to do symptom that is this disorder. That's why we give this medicine. So here are some negative valence symptoms. So the constructs of negative valence are fear, anxiety, loss, and frustrative non-reward. The symptom cluster that manifests here are things like hyperarousal and flashbacks. For example, in PTSD. That's who's getting the sertraline or the SSRI and the alpha blocker. Another negative valence symptom might be affective lability, rejection, sensitivity. Who has that? That's your borderline person who learned to act this way for some reason. Again, SSRIs for those people, mood stabilizers, and naltrexone for the reward systems. Heightened threat perception. These are the people with PTSD and paranoid personality disorder symptoms. Atypical antipsychotics for that. The chronic dysphoria loss, these are the PTSD avoidant people, SNRIs and venlafaxine for those. So that's kind of how you can organize what symptoms you are seeing. These are positive valence symptoms here. You may see them both in antisocial. What you're noticing, by the way, is you can have the symptoms and cross multiple disorders, right? That's why RDoC is more valuable than a DSM classification, because you can have impulsivity and risk-taking in borderline, in bipolar, in anxiety. You can have it in each of those. But the DSM says, nope, you have to meet this criteria to get this diagnosis. But if you're doing it this way, you may be able to use the same medication targeting the symptom because it crosses all these different domains. So these cognitive symptoms here, does it matter why you have them? No, but it provides some sort of context. But if you're having dissociation, fragmentation, this is very similar to PTSD and borderline, so much so that there is research of relabeling borderline personality disorder as eventually complex PTSD, because you will find a lot of similar antecedents to the behavior in both of those populations. In the arousal disorders, this is where you're having sleep disturbance and nightmares, and you know that can happen with a host of other conditions. And so that's who we're treating with the alpha blockers and essentially sedatives or low-dose TCAs. Goal is to restore sleep. Social processing, this is another domain. The reason I give you these cluster domains is you can then organize in your mind, where are they manifesting symptoms from? So this is how you know what to prescribe. Rather than just say this pill for that disorder. So here is the summary. Essentially, you look at the RDoC domain, consider that negative valence, positive valence, cognitive, arousal, and social processing. The DSM symptom targets, fear, anxiety, rejection, impulsivity, all of these can occur in regardless of whatever DSM criteria and the medications that tend to match with whatever symptom they happen to be having. This helps give you the rationale as to what are you prescribing and why, but also what will you monitor so you don't just keep adding medication forever. If it goes down and you teach coping strategies and the symptoms are not disturbing function, then you have grounds to come off of them. So medications can help alleviate symptoms and anxiety, but again, this is not a cure. Don't think you're curing anything here in psychiatry. There are no pills to treat the specific personality disorder, but we're just muting symptoms. And I put this here so that you can see ADHD, borderline personality, and PTSD. You can have symptoms that cross all of these pathways. Now imagine if you mislabeled somebody with their inattention and impulsivity as ADD and you decide to treat that with a stimulant, but really what you're hitting is, say, somebody with borderline anxiety or PTSD, thereby exacerbating the condition. So just because you have the symptom, you need to dig into the history of how we got here, not just take the symptom and run with it. So survival strategies often look like pathology later on. So the child who dissociates to survive sexual abuse may become the adult with borderline traits. The child who learns not to need others due to emotional neglect, that person may become schizoid or avoidant traits later in life. The hypervigilant child of an alcoholic may become the anxious adult with PTSD or OCPD, because the OCPD, what benefit can you see that? It gives a sense of control. Right? The whole point of being victimized is the fact that you felt powerless for an extended period of time, and you never want to feel that way again. So you may misdirect things that you perceive you have control over and just magnify that in your daily life to give you a sense of control. So what once ensured your survival as a child or a younger person now becomes maladaptive because you're not in imminent danger and you're still acting like you are. So how do you prescribe? And this is the review that basically pulls the whole course together. So essentially what you're going to do is start at the bottom level of Maslow's hierarchy of needs, right? You want to see the symptoms that your patient is presenting as a means of meeting a need. And the reason they came to you is for some reason it's now maladaptive and not working. So if you start at the bottom with the physiologic needs of sleep, and loss and hunger, fatigue, and pain, regulate that first and then contend with the safety issues. That's maybe why they're feeling hypervigilant, paranoid, or panicked. That's where the SSRIs may be useful. We're not going to create love and belonging with medications per se. We may create the feeling, but it's not reflective of the reality. We're not trying to trick them. We want them to truly feel safe enough where they then form a community, so then they truly feel love and belonging. And then they help the community and they have positive esteem. Not just, you're great, you're wonderful. You haven't done anything. You're great, you're wonderful. That doesn't do anything for anybody. Do something so you can be great and wonderful with somebody so they can tell you how wonderful you are. Now, you will notice that the thing that tends to trigger the traits to flare up are typically these very basic level early warning systems. Typically, hunger, anger, loneliness, and tired are the four major triggers that tend to cause the maladaptive behaviors. So if you keep this in mind when you're taking a history, you're saying, I was doing so well, and then I lapsed. What caused the lapse? Usually it's hungry, angry, lonely, tired. One of these things. I was like, I wasn't hungry. Were you irritable, impulsive? Did you skip a meal because okay, maybe you were hungry. Are you angry, Rachel? But I didn't get what I wanted. I feel I deserve. They did more than I didn't. That's so essentially, do you know the biggest predictor of a relapse is a negative emotional state? 75% of relapse starts with a negative emotional state. This just gives you a way to articulate, are you having a negative emotional state, so that we should put things in place to preempt this to make you more successful down the road. So what does that mean? You carry a protein bar, a rosary bead, you phone a friend, and remember to take a power nap, right? If we can mitigate those, we will greatly reduce the risk of essentially you having a lapse. But people are not aware of these triggers. They're also not aware of how these triggers are nuanced. It may not look the same in everybody. So you're going to help them explore, what do these triggers look like in you, and what can we do to mitigate them? So the survival function in something like hypervigilance may be to detect the threat and early warning symptoms. Where this might come from is there a history of abuse, violence, neglect? Same with emotional numbing. You want to avoid overwhelming pain. Where did that come from? Abuse and neglect, possibly dissociation. Likewise. So what you're seeing here is on the left column, you see the symptoms they may be having. The middle column tells you what survival function it may have served. And then common origins as to why they developed it are in the final column there. So these two things here are biological environmental contributions to what we're calling psychiatric disorders. Pills can theoretically help these things. Inflammation, gut-brain axis, sleep dysregulation. Pills can help that. All of psychopharmacology is theoretical. This is what we think it works on. The pills only work on biological symptoms, only on biological processes. What the problem is these things. There's no pill for this. So treating symptoms with medication might be helpful, but if someone is feeling disconnected from work, people, values, they've had childhood trauma, they have no status and respect, their natural world, or they have no hopeful, secure future, these sorts of things are what is setting the stage. These are the moderators that they're living with that is causing their symptoms to manifest, and they're coming to you to fix it. And unfortunately, we're very much a here's a pill. Well, there's no pill to give you meaningful work, connect you to people, develop a sense of value, undo your childhood trauma. There's no pill for any of this. But this is the stuff that they're coming to you with. So they're going to come to you with, I got laid off. My mother was an alcoholic and she died young. My father used to beat me. I have no prospect of a future in any job that I do. And you're going to say, how does that make you feel? And here's some Prozac. That's going to fix it? No, it's not going to fix it. So this is the problem. It's psychiatrists trying to be a little too simplistic in their approach. So the purpose of this is to give you context so that you don't overpromise and eventually underdeliver. And essentially, if you think about what's happening, is we're medicating away the complaining. But what they're looking for is to be heard, validated. In fact, there was one Kaiser Permanente study that showed that just having someone answer one of those questions in the ACEs and saying, would you like to talk about it? That alone, that one therapeutic intervention has been shown to greatly reduce downstream distress. And the where it manifested was in sleep disruption, which is the one major symptom you need to continue going after. Thank you all very much for your attention and perseverance. You have survived psychopharmacology. That's it, guys.